Okay, it's 3 minutes past the hour, so we're good to go. Good afternoon, everyone, and welcome to the June edition of PHEMS Meetup webinar series. Today's topic will be on the PHEMS Playbook. This is the last session of our spring edition, and I will be both your host and presenter this afternoon, talking about the PHEMS Playbook, which is our document guiding the evolution and development of Paediatric Health Data Space, the main output of our PHEMS project. As always, these meetup series, they start with a presentation, about 25 to 30 minutes. This presentation will be recorded and then shared on our YouTube channel for later use. Then after the presentation, we will stop the recording and enable all participants to join a Q&A and conversation session. If you have any questions or comments during the presentation, so feel free to use the chat section for that. A quick recap of PHEMS project. Why did we start this initiative related to pediatrics and data sharing? There is an urgent need in pediatrics to enable safe data sharing cross borders because there are small numbers of complex pediatric and rare diseases patients in each country, and this limits the ability to conduct research or develop new therapies and improve patient outcomes based on data, using the data that is accumulated in healthcare organizations. There's also new treatments that are coming available for children, and the real-world data to assess the effectiveness in real-world settings of these new therapies is quite limited, again due to low counts, small numbers, and we need to combine somehow forces in order to do treatment outcomes evaluation and HTA. If we want to anyhow engage with data-hungry applications like artificial intelligence or other types of applications that require a lot of data, no single center holds sufficient amount of data to be part of this, and thus we need to combine our forces cross-border in pediatrics. And in many countries, especially the smaller countries, they might have just the one or two pediatric hospitals, especially on the tertiary care, and therefore improving the clinical outcomes and operations efficiency through benchmarking and comparison between units is not possible unless we go cross-border. And for this purpose, we have built a PHEMS project, which was granted EU funding from the Horizon Europe program of 7 million euros, and we have entered the last 6 months period of our project, scheduled to end the coming autumn, with 14 partners led by Helsinki University Hospital, which is my background organization, and then participants are other pediatric centers, Erasmus Medical Center, Sofia Children's Hospital in Rotterdam, St. John de Dale Children's Hospital in Barcelona, Great Ormond Street Hospital for Children in London, Hospital in Florence, Italy, and the Children's University Hospital Latvia in Riga. Also, ECHO, the collaborative of European Children's Hospitals, is part of the consortium. And then we have technical and business partners supporting the development of PHEMS infrastructure and also enabling our sustainability and exploitation of results. Today, I will be talking about one of our key documents, PHEMS Playbook, which is a public document, will be made available through the PHEMS website and the EU portal to explain and describe what has been our path in thinking through how to build up this data collaboration between European pediatric hospitals. It can help participants or other hospitals or other organizations when they consider becoming participants in this type of collaboration, or it can be serving as an inspiration to other data space developers, how we have thought through. If we start the sort of beginning of our project, we outlined some basic principles when the project was designed. How do we want to set up this data infrastructure or data collaboration between the pediatric hospitals in Europe? And these topics were sort of outlined as the key guiding principles which we have to follow, and these are then reflected in the playbook and in the choices that we made, and trying to make these a reality. First of all, privacy preserving approach to data collaboration was selected as a starting point, where it means that we don't collect sensitive patient level data into centralized databases or data repositories, but we will enable federated analytics without the need to transfer sensitive patient level data around. This is the guiding principle for the technical development, and also has then consequences for our architecture and governance principles. The second principle was on control, so that hospitals who are responsible for the patient level sensitive data that they hold, we said in the very beginning that the policies, how and to whom hospitals grant access to this data remains with the hospitals. So we are not asking the hospitals to release any decision-making power to any third party or any centralized organization, but it remains at the hospitals. It's driven by pediatrics, so we wanted that real and important clinical use cases drive the development, and it's driven by pediatric hospitals. And this was the main inspiration and focus why ECHO, the European Children's Hospitals Organization, was invited from the start to become a participant in the PHEMS project, so that we ensure that there's a larger pool of pediatric hospitals involved than only those who are PHEMS project partners. We want to do efficiency, so enabling a decentralized infrastructure which is required so that data does not have to be moved around. But then we need some centralized components, and we wanted to balance it so that this decentralization and central components would be balanced, and we would lean on standards as much as possible. Especially the common data model was chosen from the beginning as the data harmonization standard to follow. We would do it as a collaborative effort centered around the ECHO Association, and then reaching out to other stakeholders. We would want to ensure scalability so that participants beyond the consortium and beyond ECHO members could join the activity. And of course, we have to be compliant. Already in our design stage, we were seeing that the European Health Data Space regulation is coming, and we need and want to align with the European Health Data Space regulation, and then also, of course, national and regional developments related to that. So these principles were guiding our development, and one of the work packages of PHEMS, which have been leading work package on governance and playbook, has been solving these topics, starting from these principles. The purpose of the playbook document is to prepare hospitals that they can join the pediatric health data space. They would find out on a high level what kind of commitments, legal commitments there are, what kind of technical requirements and common standards are used, and somehow get an idea what kind of resources and investment would participation require. Then an important part is to define what are the value creating activities of the pediatric health data space. How do the data collaboration happen in practice, and how does it create a value for data users who want to use data distributed in the central pediatric hospitals for their projects. And then we would need to outline the governance of the data space. What kind of structures do we want to set up? What kind of governance principles there are, and also a model for economic sustainability and growth. There has been discussion that many of the data collaboration initiatives are standing too much on one leg, single leg, so they are trying to develop a technical infrastructure or only focusing on a clinical use case, and the bit boring and detailed governance discussions may then be left at the lower intensity or lower importance, which then strikes back later on when you want to make it a permanent collaboration. So different types of gatekeepers in organizations, be they legal people, privacy people, or upper management, they want to know about the governance. How are we agreeing on things? And this is why we put quite a lot of effort in this topic. First of all, what is then the question we want to ask? If we think about governance, so what do we need to govern? So what types of things do we have to govern, and how can we govern these? On a very high level, so we of course will need to somehow set this up. We need to constitute a permanent way of collaborating. We have to somehow think about how does the collaboration evolve and what is the governance mechanism for that. And then there is the practical level, how is the operations handled and governed in practice. And this type of layered thinking has been guiding our work. We think and are proceeding so that we need a formal agreement between participants, which we call now a founding agreement of the Paediatric Health Data Space. And this sort of constitutes and sets up basic roles and responsibilities, liabilities, resources, rights and duties of partners on a general level, so that the organizations know where they are committing to. So founding agreement is formal where the organizations then commit to by signature. And as we know with agreements that of course you can modify an agreement, you can make an amendment, but it's always quite an effort to change or amend an agreement. That is why we think that the founding agreement should be relatively solid and relatively stable, so that we would not have to amend it very often. So that means that many of the things we have to agree on. How do we agree in practice? So the founding agreement states that what is the governance model and what is the ecosystem growth approach, which is already addressing the evolution of the pediatric health data space. So the founding agreement sets some principles. I will come back to those a bit later, and then there is an agreement how the ecosystem can grow. But then on the practical operation, we would need requirements for participants, what kind of technical or process requirements they have. How do we work together? How do we make it interoperable through common processes? How do we ensure that data protection and cybersecurity are handled properly? And with the ecosystem growth part, how do we onboard and offboard participants? And how do we then introduce new projects and new use cases that create value for the data users and justify the pediatric health data space to exist? If we start with the first one, the constitution, so the idea is that founding agreement is done between participating hospitals and ECHO, the European Children's Hospitals Organization. So hospitals that are part of this collaborative come together through an agreement, and they agree with the governance entity ECHO on certain principles. And this, if we think about hospitals only, so hospitals' internal data users can then make data demands to the network and also then receive services from the hospitals being part of it. And then there is a financial mechanism that is based on project-based budget and annual settlement mechanism. So this sets the basic structure. There can be many hospitals as data controllers, and then one governance entity who is part of the founding agreement. And this sets the basic relationships between these founding parties. And now, if we look at the governance model that is set, so the need for a governance model is defining really how do we accept new participants and how do we ensure that the participants fulfill the requirements that are set. How do we ensure that the documentation that is binding remains up to date and relevant, and also how do we work when there are disputes or things that don't go perfectly. If there are complaints, non-compliance or conflicts, how do we solve them? And these are then embedded into the governance of ECHO association, where this very simple organogram shows in orange what is the ECHO association currently. It's just a very simple assembly of members, a board of directors, a small secretariat, and a steering committee. But with Paediatric Health Data Space, we add some governance bodies, a management of the data space, a support desk that provides some centralized resources, and then a dispute resolution committee that is there to solve any potential disputes or conflicts. The idea is to embed this into the ECHO association, and then the participants, the hospitals, they will collaborate in the committees to work on the details of the operational rules, for example. The basic operating model of the data space is that we have hospitals in one end holding the data, and we have data users in the other end using workspaces, and we have four main processes or services that are made available by the data space. One is finding data availability, how to locate available data from the data space, how to end data permit applications to all the hospitals where data access is applied for. The hospitals themselves take the decisions whether data access is granted or not, but there is a central gateway data permit application service where data users can send their applications to all hospitals. Then there is the service for the federated data processing, so that insights can be drawn from distributed data sources. And then there's a results release, so that results that are typically aggregates or counts or statistical distributions or other non-sensitive results, they can be released from the data controller, automated and manual measures. And this is the operating model that we are defining in the documents that are collaboratively maintained in the Paediatric Health Data Space. So with this, we have the levels of the founding agreement, which is the constitution. We have a governance model that is embedded into the ECHO association, and then we have an operating model which builds on services that are then defined by binding what we call control documents, describing, for example, how a data permit application is handled. So then if we look at where do the projects come in? How does it create value from the Paediatric Health Data Space? So it's very important to understand that in the data space, we don't take centralized decisions on projects. Every project that is proposed by a data user or data users, they are decided upon by individual hospitals, each by each. Is this project something where we want to participate? And the data users are the one that create the value from their research, benchmarking, or AI development activities. What the PHDA does is that it defines what we call use cases. So what is the sort of accepted or supported type of project that can be executed? In PHEMS, we have two model use cases. One is on hospital benchmarking, where we have both a project, which is a pediatric cardiac care benchmarking, and we have defined like a generic hospital benchmarking use case. So how can you then create a benchmarking project for other topics like pediatric intensive care units benchmarking? Then there is a use case on developing AI and ML machine learning tools, where we have a project on the PICU sepsis algorithm. So there is a use case definition, and then a model project led by Sanjo and the Dale team. But another types of projects for algorithms could be developed using the same type of use case definition. We also have defined use cases for clinical study feasibility, where the idea is that the clinical trials units in hospitals, they could collaborate enabling clinical research by making a project on clinical study planning and feasibility assessment. So again, there could be several projects, and the use case defines what is the sort of generic way of building these projects. And then also scientific research using federated analytics, especially using the Odyssey tools and methods that are available for scientific research in an open source community. So these use cases are also defined in PHEMS. We don't yet have model projects on all these, but we are expecting and hoping that this will build up. And the playbook now describes what is sort of generic use cases that we are supporting, and then as example use cases, the ones that are done in PHEMS. So this is the basic logic that we are building in the project, and it's being implemented as now as the project is coming towards an end. So the participating hospitals, or we as a project, are pushing the participating hospitals to formally sign the founding agreement and become participants in a permanent board of collaboration, where first 4 hospitals will be joining: GOS, HUS, Erasmus, and Sanjo and Deo. And then we'll look forward to other hospitals joining. There are 4 others who are exploring their readiness to join: Vienna, Leuven, Oslo, and Warsaw, and also hoping to have other hospitals coming in a later stage. This then comes to the second question that we're trying to develop in the governor's work package and with the playbook, is that how do we scale? How to grow from an EU project with 6 hospitals and 3 clinical use cases to really become a pediatric health data space for Europe. The underlying logic or high-level logic would be built on really amplifying and hoping to get positive reinforcing cycle, virtuous cycle into the pediatric data, where we start by a certain amount of hospitals joining as data controllers, bringing their data resources available for federated access. And as these data controllers come together, there is a larger and richer data pool available for data users that can then execute their projects by using the data. And when the projects are being executed, so the hospitals are seeing benefits. They are seeing benefits from the benchmarking activities. They are seeing benefits from preparing and planning clinical research or machine learning model development. And this is then lowering also the overhead cost when there are projects that are being run, because then projects can be charged some money in order to maintain the infrastructure and the ecosystem. And then if we have benefits and projects that are successfully run, we can develop new use cases. So new types of use cases can be agreed upon, and this can attract further new hospitals to join as data controllers. And this might hopefully lead into a growing path where in a few years' time, so the growing of the data pool by new hospitals would attract increasingly data users to do projects, and this would then create value back to the hospitals, justifying the investment and also lowering the running and overhead costs that are related to this collaboration. One of the challenging parts in this setup is that hospitals are not maybe the best in providing like packaged services for data users. And therefore, to support scalability, we have together with the Genesis Biomed team, who is developing this exploitation sustainability model for PHEMS, defined an architecture and introducing a new type of role, which is called access provider. The access provider could be a commercial company whose role is to become contractually bound to the rules and common principles of the PHDS, but its role would be to serve external data users. So to provide a service offering which could meet to different types of data needs, also external to those of hospital data users. They could reach out to other academic researchers, to pharma, to MedTech, or contract research organizations who all have demand for access to pediatric data. We could have several access providers who could serve a different clientele, and in this way, the hospitals as data controllers can focus on improving their data source, making sure that data access is working to their hospital, making sure that the processes for applying and granting the data permits are smooth, so that the timely access for data users can be guaranteed. But then the access provider role can provide add-on services to data users, more market-driven way than public hospitals are used. But still, it would be under the governance and the common rules that are defined by this ecosystem. But we hope that this mechanism can then support scaling to other types of data users than only hospital internal. Of course, when we then include and increase the amount of organizations and partners, we come to a question of trust and how do we enable mechanisms which allow different parties to be sure that the partners that are there are really who they claim to be. That's why there needs to be some sort of trust framework, and this is Currently, the idea, what we need to, again, a layered approach where there are means to verify what organizations or network users are, who they claim they are, and that can be controlled, both their access and their participation in the network. Starting from technical infrastructure, of course, the different nodes have to have a trusted certificate for technical access. Then the second layer being who are the official partners in this pediatric health data space, and what kind of role do they have, and do they have an agreement in place that has not been revoked, for example, due to non-compliance. And this is handled and will be handled through a trust registry. Then for the third layer relates to users in the network. So there are three types of users. There are data controllers, so those who grant the data permits to access data in each hospital. There are the researchers or data users who are using the data. And then there are projects. So these animals that come together that are using data from several sources. And this is where we aim to lean on digital identities and credentials. Hopefully the European infrastructure for digital credentials is moving forward, that could provide us a sort of like a ready-made infrastructure for this trust layer. And then for the highest layer, data objects. So how do we deal with controls on results? How do we release non-sensitive data? How do we make a registry of trusted algorithms, trusted analytical codes and models? And this is then enforced by policies, where hospitals can say that our policy is that nothing can be run unless our people have checked it, or it can be a policy which says that if somebody who we trust has checked this, we also accept that. So there is a way to build a policy that the hospital is comfortable with, and when trust increases, so these policies can then be adjusted. So we need to have mechanisms for trust and the verification of different participants. And then the final topic about the scaling is of course that we need to have binding agreements, and the structure of the agreements is such that we hope also that this scales well. We have what we call the constitution or the founding agreement, which is made between the founding hospitals, but other pediatric hospitals who are members of the ECHO, they can join this founding agreement simply by an accession document. Other organizations can join the Pediatric Health Data Space through a role-based agreement, meaning that the governing entity ECHO has the mandate to enter into contracts with other hospitals to become participants in the Pediatric Health Data Space, or access providers to become participants in the Pediatric Health Data Space based on a role-based agreement. So we can have as many data controllers, as many access providers as needed, without the need for everybody to agree with everybody on everything, because this will then become unmanageable if things scale. And then we have a set of control documents that are binding to all parties, but they are things that are evolve over time, and the governance committee of Pediatric Health Data Space will see that these documents are up to date, and if there are disputes or things that need resolution, there is the dispute resolution mechanism also available. So all in all, the playbook as said, that will be a public document. It tries to explain this logic and also how we have worked with it in the PHEMS project in building the Pediatric Health Data Space and the foundations. And the key thing here is really that there are certain principles which we have followed, and then there are layers of governance and layers of agreements that we have to make. Some are formal agreements, and some are binding documents that are managed according to an agreed governance model. And this all anchored into the ECHO association that becomes then a hub for the governance activities. ECHO association will not have anything to say about what types of projects will be run. Data users will define the projects, and the hospitals as data controllers, they will decide whether they grant access to these projects on data or not. But ECHO will run the governance part of it, and also then work with the expansion of the network to include new hospitals and new access providers into the pediatric health data space.